We can begin now.
I think we're on now.
Yes, doctor, we are live. We can begin.
Thank you very much. So hello to you all. I'd like to thank the Oman Ophthalmic Society for the invitation and thank the very distinguished faculty that needs no introduction. Each of them is an authority in this field. I'm grateful to them for being with us despite their very busy schedule. Professor Ahmed Assaf from Cairo, Egypt, and Professor George Daoud both are not going to be with us due to internet problems. I'm sorry to say this, but Dr. Assaf just sent us his video. So we're going to listen to his video. Please, without further ado.
Hello. I would like to thank Dr. Anas Al-Ambari for his honorable invitation. And I would like to congratulate as well Dr. Rashid Al-Saidi for this excellent program of the Muscat International Ophthalmology Society annual meeting. I will talk to you about the surface ablation for early cases of keratoconus, and I don't have any financial interest in any of the subjects mentioned in this presentation. As you know, cornea cross-linking was first developed in the late 90s and it proved to stabilize the cornea for more than 10 years. However, in some cases, patients are not satisfied by the quality of vision they gain because of the corneal irregularities. Topography-guided PRK for early cases of keratoconus and some selected cases of post-LASIK ectasia is aimed or suggested to normalize the corneal surface and improve the best corrected visual quality. This approach should be combined with cornea cross-linking, so I would prefer to do this approach after stabilization of the cornea by cornea cross-linking after 1 year or so. My personal selection criteria is cases of early keratoconus of grade 1 or 2, best corrected visual acuity of 0.5 or less, as long as the patient is not satisfied by his or her spectacles. Kmax should be less than 50 diopters, irregular corneal astigmatism on the surface of the cornea by the topography or the pentacam should be less than 5 diopters, and of course the cornea thickness should not be less than 470 microns because we need around 50 microns of ablation during the procedure. The goal here is to reduce the corneal aberrations and convert the irregular corneal astigmatism into regular corneal astigmatism, and hence we can improve the corneal higher order aberrations and best corrected visual quality. It's not a procedure that aims to spectacle independence, and this message should be delivered clearly to the patients because most of the patients relate laser technology to refractive procedure. This is a therapeutic procedure to improve the best corrected visual acuity and quality with spectacles, not to eliminate spectacles. Data acquisition in office, I rely on Scheimpflug image to analyze the corneal astigmatism by Fourier analysis, and on the day of the surgery, I get the data on the surface of the cornea by the oculizer 2 or Placido topolizer value. I usually address corneal irregularities based on the data obtained by the oculizer 2 or topolizer value, and trying to as well to debulk some of the corneal astigmatism based on calculations on Fourier analysis on pentacam that I'm going to explain in a few moments. Usually the optic zone is around 6 millimeters, sometimes 5.5 millimeters or 6.5 millimeters, but on average it will be, most of the cases is 6 millimeter, and the maximum ablation depth should not exceed 50 microns of the corneal tissue. This is an example of a lady after corneal cross-linking of early keratoconus, or you can say foam frost keratoconus, and this is inferior stippling, and you can see here that the patient is not satisfied by her quality of vision. The best corrected visual acuity is 0.5 or was not improved to more than this, and the patient was not happy with the spectacles and complained of some ghosts and shadowing with the spectacles, and you can see here with the thickness, with the corneal thickness profile, the D value is abnormal, and there is early migration of the corneal thickness from the normal values. So this is a case of early keratoconus, and we approached this lady to improve her quality of vision by the laser vision correction on the surface of the cornea. You can see here with the Fourier analysis, we could decompose the astigmatism. This astigmatism is coming from the decentration based on Fourier analysis, which is the coma, and some of the regular component of the astigmatism. We can calculate the amount of regular astigmatism by calculating the difference between the flat and steep axes on the Fourier analysis. So in this case in particular, it was 2.3 diopters. So this is our main target here, is to normalize the corneal surface by addressing the coma, and as well we can debulk around 70-75% of the regular corneal astigmatism to improve the quality of vision of this patient after the procedure. So this is our surgical planning. This is before entering any cylinder value. Here you can see this is the ablation profile without any refractive data here, and the maximum ablation is around 17 microns, and we can even include some of the regular corneal cylinder around 1.8 or 1.75 diopters to debulk some of the corneal astigmatism, and still we are less than 50 microns. So we started the procedure this way, and we could improve the best corrected visual acuity to this lady to 0.9, and you can see that we could reduce the corneal astigmatism to 0.25 diopters after the procedure. Of course, the patient has some myopia, and I stress that this procedure is not a refractive one. It's rather to improve the best corrected visual acuity. You can see here I usually start with a topography guided PRK, not PTK, and this is followed by the PTK, and finally mitomycin. You can see the laser starts to hit the stroma on the tip of the cone quite early compared to the other locations of the cornea because of the thin epithelium on top of the cone of the keratoconus. This is another case of female again with inferior stiffening, and she is not happy with her quality of vision. With the Fourier analysis, we can decompose the astigmatism the patient has into a coma and regular component. And surprisingly, you can see that the regular component of this astigmatism is almost trivial, or is almost zero and can be ignored. And most of the astigmatism translated by refraction comes from the coma on the surface of the cornea. So during the surgical planning, we didn't enter any value for the cylindrical correction. We included some of the myopic correction to improve her visual quality and to reduce maybe spectacle independence, but this is not the aim, the main target here in this case, just to improve the quality of vision. But if the corneal thickness and the ablation depth allows for some of the spherical correction, we can include the spherical correction in our procedure. So you can see here, this is before the procedure and this is after the procedure. You can see improvement in the corneal shape and almost normalized central cornea, and this is the differential map. You can see we could flatten the inferior part of the cornea to correct the inferior stippling before the procedure. This is another case of male patients with relatively flat cornea with inferior stiffening, and the patient of course was not happy with his quality of vision. And again, with the Fourier analysis, we can decompose here. This is most of the corneal astigmatism comes from the coma, and the regular corneal astigmatism, by calculating the difference between the steep and flat axis, was only 1 diopter. We can still include some of the correction of the regular corneal astigmatism as long as the ablation depth is less than 50 microns, and some of the spherical component as well. Again, this is not our main target for spectacle independence, but rather we can debulk some of the cylinder and some of the myopia if the ablation depth permit and if we didn't exceed the ceiling of 50 microns of ablation depth. Keep in mind that these patients have relatively thick cornea compared to the other cases of keratoconus. As I mentioned before, that my inclusion criteria is cornea thickness of 470 microns or more. So you can see here improvement in the quality of the corneal shape. Almost the central cornea has been normalized, and with the differential map you can see we could achieve flattening of the inferior steepening of the cornea and steepening in the upper half of the cornea, so to normalize the corneal shape. What about the higher order abrasions on the corneal surface? You can see in this example we had significant improvement in the vertical and horizontal coma pre-op and 2 months after the procedure. What about the visual quality? This is the visual quality map of the OPD3 scan. You can see this is the point split function before the procedure, this is the modulation transfer function, and this is the total ocular aberration, the total coma, trefoil, and spherical aberration. And you can see after the procedure we have tighter point split function, improvement in stress ratio, improvement in the modulation transfer function, and reduction of the ocular coma, trefoil, and spherical aberration. This is another similar example you can see here. This is the point split function, and this is the modulation transfer function, and this is the total ocular coma, trefoil, and spherical aberration. And after the procedure we had improvement in the corneal and the higher order aberrations, improvement in the modulation transfer function and stress ratio. We conducted a study of 35 eyes of 20 patients, and we had significant improvement in the best corrected visual acuity and significant reduction in the vertical coma, horizontal coma, total ocular coma, as well as improvement in the stress ratio. So my take-home message that laser surface ablation can improve the visual quality in cases of early keratoconus and post-LASIK ectasia. Fourier analysis is helpful to understand the components of the corneal astigmatism, and it's helpful, of course, for surgical planning. And this procedure can be applied on the same day with corneal cross-linking, like the Athens protocol, or sequentially around 1 year or so after corneal cross-linking. This procedure does not increase the corneal haze and has no specific complications. Thank you very much for your attention.
Thank you very much, Amir. That was very interesting, and it's good to have you with us. It seems that you're on your mobile.
Yes, exactly. Hi, how are you?
Thank you for taking the trouble.
Ahmed, how are you?
Hi.
Just a quick question. Have you ever considered the corneal rings in cases? And if you did, so why not?
Of course, corneal rings has its place in cases of keratoconus. I mean that this procedure is only beneficial for early cases of keratoconus with thick cornea, relatively thick cornea, around 450 microns. So in some cases with the very thin cornea or advanced keratoconus like keratoconus stage 3, for example, and high astigmatism or highly irregular cornea, this procedure is not applicable because you need a hammer to flatten the steep areas of the cornea and to normalize the corneal shape. So I do believe that this is not a substitute of corneal rings, of course. Thank you very much for this question, by the way, because this is a complementary, or it can be, has its place for early cases of keratoconus, but of course the corneal rings has its place for advanced cases of keratoconus like keratoconus grade 3. With high astigmatism, for example, 6 diopter of astigmatism or more, of course, this surface ablation has no role to flatten or to normalize the surface of the cornea. Sometimes the cornea is so much irregular. So I believe in this case, corneal rings has its unique advantage.
Great talk, and I appreciate you being with us.
Thank you.
Now we move to Dr. Rashid Al-Saidi. He's like to start your talk, please.
I will share my talk now.
Yes, please.
First, good afternoon, everybody, and would like to thank Dr. Anas for organizing this talk, and would like to thank our speakers and our attendee also and delegates for attending our conference. And our conference won't be successful without your contributions and great contribution. Thank you very much. My talk today about one size does not fit all. It's customized KXL protocols. Okay, I have no conflict of interest. Why in Oman we care about keratoconus too much? Oman, one of the highest rate of keratoconus worldwide. We did a simple study in one big center, and we found minimum 7% of Omani they have keratoconus, some degree of keratoconus. Second thing, Oman, a big country, an old country, where most of the families being here living for a long time in the country. So we found some families, they have clusters of keratoconus. They have the whole family keratoconus positive, different degrees. And that's why we were looking for a way. We started actually, in our center, one of the first centers started keratoconus diagnosis and follow-up and treatments for different type. We have more than 10 years already in the field, making cross-linking for the patients. I will brief you about our center serve approximately 1/3 of Omani population, more than 10 years experience in managing keratoconus, pediatric clinic, regular screening for keratoconus we have, in addition to community-based screening. Dedicated keratoconus clinic and contact lens clinic we have dedicated in the clinic. We cross-linked all pediatric cases without delay, thinnest pachymetry in the till now 400 microns. All thin cornea below 400 with progressive KC are managed conservatively and address allergy and eye rubbing and contact lens we are offering, and we are waiting if they go into hydros, maybe they get keratoplasty in the old time, of course. To date, KXL is recommended for cornea with a minimum thickness of 400 microns. To date, I mean that time when we started the study this last year, and above due to safety tissue. Different KXL methods for this cornea have been tried without much of success. Some people, they try to put tissue, contact lens, or AB on, AB off. Patient with thin cornea and progressive KC eventually end up with eye drops, as we know, and scarring of the cornea. Keratoplasty is the last options like DALC or PKB. So customizing the KXL protocol to suit the thin cornea is safe and effective, we found from this study. As you know, the cornea thickness, we can control the thickness if we can guarantee safety of endothelium. Then from this study, we can customize our KXL so we can do for even thin cornea, as you will see now. We know AB off, the usually available of epithelium will cause more delay in the UV light will not reach deep, but AB on, AB off, I mean, we can go deeper, sorry, and AB on, we cannot go deeper on the cornea. But we can customize both to reach to like Dresden KXL, but this takes long time, and many people, they try to avoid Dresden treatment nowadays. As you know, the Professor Mazoda Cosimo has put like normogram, normogram, this customizing the riboflavin soaking time, UV light radiation, UV irradiation, and energy dose, so that different thickness of the cornea get different protocols. You can see here this many factors, as Professor Mazota had mentioned in his paper. Long-lasting stability of the TASIC can be achievable if at least the 2/3 of the baseline cornea thickness is saturated by cross-links. Safety endothelium, of course, UV light beam profile, length of riboflavin pre-soaking time, and viscosity of riboflavin film. The riboflavin administration timing. So all those factors, if we control, we can reach to customize and the patient will get cross-linking and will stop going into high drops and advanced cases. Here, when here one paper published by him, by Professor Mazzotto, famous pachymetry-based accelerated cross-linking. Then M nomogram is standardized treatment of all thickness progressive ectatic cornea. The conclusion of the study is a customized KXL M nomogram allows safe and efficacious cross-linking parameters setting based on pre-operative minimum corneal thickness, also including more standardized treatment of thin ectatic cornea between 250 microns and 400 microns. This another study, pulse versus continuous light accelerated corneal collagen cross-linking in vivo qualitative investigation by confocal microscope and corneal OCT. And pulse light, as we know, continuous illumination can be an option for treating thin corneas. How did we customize treatment protocol according to the pachymetry? Our standard protocol 400 microns and above the normal one, which we are practicing in the since long time. That's been epithelium of 8 millimeters. We remove the epithelium, and we know the energy standard 30 micro, and UV power we standardize 7.2 joule. Fluence, usually we use pulse illuminations, 10 minutes soaking with the isotonic riboflavin, 1 drop every 2 minutes. No here in the normal one, no riboflavin application during UVA in the normal protocols. But in the customized protocols, we apply riboflavin every 2 minutes during UVA light. This is the difference. So far, we have achieved good results. Our failure rate in the normal standard protocol above 400 microns, we have only in our center 5 to 7%, despite having many advanced cases failure, only 5 to 7%. But we do, don't forget, we do every year more than 140 cases per year. Here, case one, we have here one interesting case, 16-year-old school girl, first visit at ophthalmology center on 15 September 2019. Chief complaint was deteriorating vision in both eyes, not using glasses, not known to have previous ophthalmic or medical problem, found to have both eyes keratoconus, stage 3, Fox stereo there, Fleischer rings there also, otherwise clear cornea in both eyes, no apical scarring. You can see here from this drawing here, you can see the vision right and left. Of course, right eye worse. And you can see Kmax, right eye 67.6, and this one 57.6, and the difference 10 almost, but thinnest pachymetry, right eye 300, almost 360, and this one more than 380. And because it's near 400 left eye, we started left eye, we did it before this customized protocols, we did it with the normal protocols. You can see here the same, both eyes, you can see here the thinnest point, and Kmax and Kmax here, 54, the left eye. Treatment guideline for this patient, high risk patient A, keratoconus pachymetry, risk of KXL complication due to thin cornea versus conservative, versus conservative management. First, we do what we do in our center, counseling of the parents regarding all pros and cons. Parents agree to take the risk, go for KXL, because patient, they will complain if anything happened to them. Plan, EB off, cross-linking for the left eye, the better eye first. M nomogram was not available at that time when we started this eye. Decided to go for continuous illumination instead of pulse to use less fluence. Stromal depth will be less, hence more protection for endothelium. Treatment setting, left eye. Epithelium of 8 millimeter we removed. Power was 30 standard. Fluence was 5.4 joules. Continuous illumination for 3 minutes. 10 minutes soaking with isotonic riboflavin, 1 drop every 2 minutes. Pachymetry pre-op 395. After removal of epithelium 366. After soaking with riboflavin, pre-UVA was 390. You can see here, sorry. Can see here the demarcation of the, almost demarcation of the cross-linking. Can see it clear? Here the date of surgery done in September, follow up so far up to 1 year. Very good. You can see here the progression. Kmax with the normal 57.6 pre-op, 1 month 58.7. This and this one 3 month post-op, and you see stabilizing over the time. And although the thickness not much of stabilized, but the Kmax stabilized, and this was good treatment for a patient around 400 micron. You can see here pre and post-op, Kmax 57 and 57.1 post-op, same eye, left eye. That's why there's improvement. And here you can see over almost 1 year follow-up from 53, 55, and then post-op 54, 54.7 over 1 year stabilized. This is the normal cross-linking. Now the right eye, the difficult eye. Plan to do a right eye cross-linking 4 months after left eye. Now we have the M normogram. We customize the protocol for thin cornea according to the M normogram. Protocol for bachymetry between we use protocol for bachymetry between 350 and 400 micron. Treatment setting, epithelium of 8 millimeters as standard. The power was 15 milliwatts and 5.7 joule fluence. Pulse illumination 1:1, total 12 minutes. 10 minutes soaking with isotonic riboflavin, 1 drops every minute. Riboflavin, 1 drops every 3 minutes during UVA. This is the difference between the customized and the normal cross-linking here. During the UV light, we soak the eye with riboflavin every 3 minutes. Calculated demarcation line 280 micron of stromal depth on average range of 250. This is our target. Bachymetry pre-op 356. After removal epithelium 384. After soaking with riboflavin pre-op 366. Here you can see the depth we reach. Depth of the customized cross-linking with our protocol. Surgery done in February 2020. Follow up so far, one day, we do it 1 day, 3 months, 6 months, and no complications seen for this patient. Epithelium was healed by 7 days. Endothelial cell count was normal, not changed. Mild central corneal haze, grade 2, noted in the last visit, which is after that was okay in the last visit from the study. You can see here the same eye, left eye here, Kmax from 67.6. First visit, of course, second visit, pre-op 68. So progression very quickly actually in this patient. You can see here 1 month, not much of change, but 3 months, there's change already. And after 6 months, until now it's improving. And although the thinnest bachymetry stabilize more or less a little change, which is could go with the eye dryness or something like this. Here we can see the same eye, right eye, a thickness pre-op and post-op. Kmax also, Kmax 68.1 and pre-op 68.8, almost 7 degrees. Here we can see same right eye, pre-op and then post-op, first visit post-op and 6 month post-op. This improvement very clear and stabilization of Kmax. Conclusion, KXL protocol can be customized to suit the bachymetry reading by adjusting the riboflavin soaking time, UVA power, and exposure time. Demarcation line can be used as an indicator for assessment of treatment efficacy. M normogram is a useful tool to pre-calculate the demarcation line and adjust treatment setting accordingly. Thin cornea below 400 micron is no more contraindication for KXL. There's new hopes for patients with progressive KC and thin corneas. Thank you very much.
Thank you very much, Dr. Rashid. Just a quick question, please. What was the thinnest cornea that you've done?
We did till now around till up to 340. We are 340 or around so, and we are careful. We don't want to go below 300 till we get good experience with our patient.
So you're
So we are
going
going now
300?
340 we are doing nowadays.
I see. And any safety precautions that you like to tell us about?
Until now, we did not see any contraindication, but because as we are in the center new in this time, we want to go slowly down, till we reach to 300 maybe and around 300.
Okay. Looking forward to hear
And
future
we are going to continue the study and watch and report that to the colleagues everywhere.
Thanks very much indeed.
Can I make a question, Anas?
Hi.
Hello.
Hello. Very nice talk. Very nice talk. You know, I was going to ask to you about the safety of the procedure in thin corneas, because recent information, and this comes from Hafesi and others, really makes an outstanding issue about endothelial cells to be resistant to ultraviolet light. So it seems that it is much more a myth than a real thing, that we run into risk of UV damage for the corneal endothelium, because the fluence that is necessary to kill the cells is about tenfold the one that we use, you know. So being this in mind, it might be that we have no need for such preventions, you know. It might be that we can just cross-link these corneas, even epi-on, which is what I do. I do epi-on, and if you are aware of any recent report about endothelial cell decompensation, look that there is no report in the literature. So I think that we're overestimating the damage that can be potentially happen to the corneal endothelium, and might be that we can be more aggressive with less risk. And what do you think? What is your experience about that? Have you had any corneal decompensation based on cross-linking performance in thin corneas?
Actually, I tell you the truth, we are very careful with those cases, borderline. We try to avoid them, but we are going slowly down. We are keeping minimum 50 microns safety, plus we are soaking the eye during the UV light, so that will help and make the cornea a little bit thicker and maybe protection, but we did not encounter till now any case of endothelial decompensation from our study group in our center.
Yeah. And the question is, do you have Down syndrome cases in your?
Yes.
Because, you know, it's a problem, because we have published recently in JAMA Ophthalmology the Down syndrome keratopathy. So these patients have a keratopathy, all of them. You know, it might be that they have keratoconus, but they have sometimes irregular corneas and they are not keratoconus. So it seems that the problem is the keratopathy, because, you know, in these cases, cross-linking, we do as in every case, once that we know that there is a keratopathy. What do you do with Down syndrome cases with irregular corneas?
Actually, we did we have Down syndrome cases, and we did some kids, children with cross-linking but we did not do any case below 400 for Down syndrome. And kids in general, we could not do because we are worried that not much of information we have about children.
You know, in these cases is when we do epi-on, because, you know, these children are a hell in the office when they have pain. You know, they suffer a lot, and they cannot express themselves. It's very, very difficult to manage. With epi-off, you know, even that you need to repeat it in 4 years might be really, we get stability. We don't have data because this is a rare disease in Europe. We don't have that many cases. You know, we have about probably 100 only. But in your countries, Down syndrome is more frequent. I really encourage you to look into your cases, because it's a very particular group of patients that need a lot of care, and we can prevent a lot of problems in this nice group of patients.
Of course. Thank you for this.
Thank you.
Great talk. Thank you.
I'd like to give the floor to Professor Hanoush. Happy Thanksgiving. Thank you very much for being with us. We look forward to your DLK talk, please.
Dr. Hanoush, you need to unmute yourself.
Are we good?
Thank you.
Wonderful. Well, thank you, Anas, for inviting me to join you this morning. I want to thank Dr. Saidi for his continued leadership. It was a pleasure to be with you on March 30th, 2019 in Muscat, where you and the Sultanate of Oman hosted us in a royal way. So we have wonderful memories, and hopefully we can do this again in the not too distant future. My charge today is to talk to you about deep anterior lamellar keratoplasty. Hopefully this will be a procedure that will not be necessary in the future if the work of Dr. Saidi, Dr. Alio, and others with collagen cross-linking proves to possibly eliminate the need of keratoplasty in the future. But anyway, that's my charge today. So I have no financial interest in the, I'm not able to advance here.
Doctor, give a click on your presentation once.
There we go. Okay. No financial interest in the subject matter of this presentation. I'm a consultant for COA. We are working on Descemet stripping only with and without Riposidil. All righty. So for many decades, the only procedure available to us for all types of corneal abnormalities was a full thickness transplant known as penetrating keratoplasty. About 15, 16 years ago, we started doing layer-specific keratoplasty to address problems in the cornea that were not necessarily affecting all layers of the cornea. And all of you are familiar with this phenomenon over the past decade and a half. With DULC, we are able to replace the anterior 96% of the cornea, and with endothelial keratoplasty, all types of endothelial keratoplasty, DSEC, DMAC, PDEC, as you'll be hearing from Professor Agarwal shortly, we replaced the posterior 4% of the cornea. Indications for DULC, obviously, are corneal ectasias, all types, stromal dystrophies, and scars from previous infections. Obviously, this is not a procedure for any patient with endothelial decompensation of any sort. The advantages of DULC, as you all know, is preservation of the host endothelium. It's a huge advantage. If you do not require donor endothelium, it eliminates primary endothelial graft failure, eliminates endothelial graft rejection, which is the major form of rejection in all transplantation, and by definition then decreases the incidence of allograft rejection. What is not discussed often about the advantage of DULC is the fact that you do not have open eye time. The absence of an open eye decreases the risk of posterior pressure, suprachoroidal events as effusion and hemorrhage, and therefore makes keratoplasty a safer procedure. When I first met Professor Muhammad Anwar in 2002, 2003, he tried to explain to me how this procedure works, and obviously there were some challenges understanding it. Now, that's obviously 18 years ago, but I created this animation to share with our trainees and colleagues how this works. So we are tree finding usually to 300 micron depths, and then we will start debulking the cornea. But before that, watch what I'm doing here. If everybody will pay attention to the insert here, the needle or the cannula now, we don't use the needle anymore, is not necessarily in that potential space, but rather in the posterior stroma, so that the pathway of least resistance for the air is posterior. So as we start injecting air and creating the air wave in the cornea, if you watch the insert, it's cleaving off either Descemet's membrane or the pre-Descemet layer, and we'll talk a little bit more about that. Okay, so once that's achieved successfully, we will now debulk the cornea. Some surgeons prefer to debulk the cornea first. That has some advantages and some limitations, which if we have time, we can discuss. After the cornea is debulked, the next step is to decompress the anterior chamber. Again, please watch the insert up here. And if you'll pay attention to the insert, as I decompress the anterior chamber, Descemet's membrane / the pre-Descemet layer will move towards the iris, all right? And now comes the brave slash. When you do the brave slash, the whole Descemet membrane PDL complex will move forward more anteriorly. If you'll watch carefully, as soon as the knife is put into the bubble, that complex will move forward, and there's a risk of cutting it with the knife. After that, the procedure is quite simple. You basically remove the posterior lamella, and we use curved scissors that are not sharp, and I'll show you why we do that, obviously. And once that is done, we are either burying the pre-Descemet layer or we are burying Descemet's membrane itself. The donor now is prepared by stripping off the Descemet's membrane and endothelium. And once that's performed, we can graft the cornea onto the recipient bed nicely with using the technique of your choice. All right, so when I show an animation like this, the audience is concerned that I don't have real video to show. Obviously, that's not true because we've been doing this for a long time. So here is a patient with moderately advanced keratoconus who had an intact ring segment placed in their cornea. He did well for many years. The ectatic process continued, so he came for keratoplasty. I removed the intact ring segment using the Hanna tree find to 90% depth, to 300 microns, I should say. And then that's the famous fluid wave that all of you have seen. So I'm going to stop here and make a point that the fluid wave itself, this emphysematous wave, is not the big bubble. But as soon as the big bubble starts developing, there is no doubt in your mind as a surgeon that that's the big bubble. That round contour is unique to the big bubble. At that time, when we started doing this, we did not know if this was big bubble 1 or 2, but now we know that this is a big bubble type 1. It usually goes out to 8.5 millimeters and can go beyond the trephination mark. At this point, I'm confident that I have a big bubble type 1. I will debulk the cornea. I will put a bubble in the anterior chamber, the brave slash, remove the posterior lamella. And for about 7 years, I would be telling my residents and fellows, all our trainees, that once we removed the posterior lamella, we were looking at Descemet's membrane. So I truly believe that at this point, I was looking at Descemet's membrane. Obviously, you all know that I was not looking at Descemet's membrane, but that took a seminal paper by Professor Dua from Nottingham, the United Kingdom, to teach us that. So we'll talk about that in a little bit, but big bubble type 1, which you saw in that video, occurs anterior to the pre-Descemet's layer, also known as Dua's layer. It usually develops from center to periphery, does not easily expand, and does not easily burst into the anterior chamber. That's big bubble type 1. Now, the structure that it's leaving behind, that's called the pre-Descemet's layer, discovered by Professor Dua, is 5 to 20 microns thick. It has about 5 to 11 compact lamellae of collagen fibers, predominantly type 1 collagen with high content of elastin-like fibers. There are very few fibroblasts at that point of the cornea. It has a high bursting pressure. This is the most important thing about creating a big bubble type 1. So you are leaving a complex of Descemet's membrane together with the pre-Descemet layer that is resistant to bursting. So you have a bursting pressure of higher than 500 millimeters of mercury. And if you followed Professor Dua's work, you know that it's continuous with the trabecular meshwork. So now we know that I am looking at the pre-Descemet layer here, not at Descemet's membrane. So I can confidently peel off Descemet's membrane off the donor and bring the stroma onto the recipient bed, and then you can suture it in place using the technique of choice. All right, so basic deep anterior lamellar keratoplasty. Well, what's the story with big bubble type 2? Well, this is a bubble that occurs posterior to the pre-Descemet layer, but anterior to Descemet's membrane. It was previously thought to be intradescemetic air dissection. We now know that not to be true. This is anterior to Descemet's membrane. It usually develops from periphery to center, and it can very easily burst into the anterior chamber, as you will see shortly. So this situation, if you recognize it correctly, i.e. big bubble type 2, is fragile since Descemet membrane has a low bursting pressure. there's no need to convert to full thickness transplantation. The surgery can still be finished successfully by attention to detail and lots of patience. For those of you who will ask about big bubble type 3, that simply is a combination of 1 and 2, and that can happen sometimes in certain procedures. So when I performed the procedure you're about to see, I truly did not know the difference between big bubble 1 and 2. So we're talking now in this video, 2007, 2008, and I thought all big bubbles were the same. But something interesting happened. Look at the creation of the bubble. Look how it's going all the way to the limbus. Look how clear there is. There's no inficematous dissection of the stroma. So what's different about this bubble? We now know that to be a big bubble type 2. Well, how do we know that? Well, here we go. I thought it was the same type of big bubble. I thought I was getting better at my surgical technique. That's why I was not getting a lot of emphysema in the cornea. I was wrong. I had a big bubble type 2. Watch carefully what happens here. I'm very confident in my technique. I'm removing the posterior lamella, not paying too much attention to where my posterior blade is, and I pop into Descemet's membrane. That would not have happened with Dua's layer, but it will happen with a big bubble type 2. So that does not mean you need to abort the procedure and convert to a full thickness transplant, because you have all this healthy endothelium, the native, the host endothelium. If you watch carefully here, you'll see that I have a full thickness defect in Descemet's membrane. And the only reason the air is not coming out is because there's surface tension on the air bubble. There's a trap door of Descemet's membrane. I'm going to just flap it down, and then you proceed with your DALC and put the graft on as you normally would. Now, if you have access to intraoperative OCT, nice to have, a little bit pricey, you can obviously observe where your cannula is when you're creating the big bubble. You can make sure that a big bubble is created. You can make sure that you don't perforate by giving more attention to detail. The cannula is anterior to the pre-Descemet layer, and it's a nice thing to have if you have access to this technology. For the next couple of minutes, I'm going to go over some pearls of how to avoid problems with DALC. So one of the things that I see our trainees doing is they will prepare the donor tissue and they will be quick to remove Descemet's membrane off the donor cornea. Do not do that. You do not know if you're going to be successful at doing DALC. And if you have a healthy donor endothelium, do not sacrifice it until you are sure that your procedure will be a DALC, not a full thickness transplant. So wait until you've debulked the posterior lamellar tissue before you sacrifice Descemet's membrane off the donor. Also, when we talked about the brave slash, we mentioned that when you put your knife into the big bubble, you have about 200 milliseconds before Dua's and Descemet's membrane will come up and may be lacerated by your knife. One way to avoid that is to put a cohesive viscoelastic on the stromal bed. This will give you plenty of time to withdraw your blade, and then you can put the viscoelastic into the lamellar space anterior to the pre-Descemet's layer. Note, I'm using the term pre-Descemet layer and Dua's layer synonymously. All right. If you are someone who likes to play loud music in the operating room, this is the time to turn it down, because you want to hear abnormal things happening. What's going on here is I had a beautiful big bubble, or at least I thought. It looked a little bit different. I was not sure that it was a type 1 or type 2, but I was convinced this was a type 1. But it did not dissect peripherally all the way to the trephination mark. This is something you can finish manually. There's no reason to keep injecting air, because what I did here, despite quite a bit of resistance, I injected and injected until I popped into the anterior chamber. Okay, so lesson learned: if you get significant resistance after you've completed a very good big bubble, this is the time to stop. You can always finish this manually. So here I should have stopped, but I kept injecting, pop into the anterior chamber. All right, does not mean I had to convert, but there was a lesson learned. Okay, so don't do that if you get a lot of resistance. Now, most of us who do cataract surgery tend to make our paracenteses kind of shelved and parallel to the iris. This is not a time to make that type of paracentesis. Whether you are someone, a DELC surgeon who makes a paracentesis before creating the big bubble, or like me, after creating the big bubble, you want the paracentesis to be more vertical because you do not want to injure the big bubble internally. So here's an example of debulking the cornea first. I'm going to put air in the anterior chamber. The big bubble has been created. And you can see that, and this has been published in many articles in the literature, when I'm putting the air in the anterior chamber, it's dancing around the big bubble. So there's no doubt in my mind that I have a big bubble type 1 here. And I'm going to proceed to explore the space between the posterior lamella. It's nice to use a marginal dissector to explore that space so that you make sure that when you're removing the posterior lamella, you are not injuring the predestimate layer or Descemet's membrane. So it's always good to explore that space with a marginal dissector. And then you safely remove the posterior lamella and put on your graft. So here's an example in my early DELC days where I thought I was getting good at this. And I went ahead to remove the posterior lamella. Watch what happens. Okay, I tore into the predestimate layer and aqueous came out. Made the procedure a little bit more difficult. Again, not a reason to abort this procedure because I could still place an anterior stromal layer and continue with my DELC, but it made it a little bit more challenging. I had to leave a bubble at the end of the procedure, and the chance of a double anterior chamber is a little bit greater. So make sure you separate the posterior lamella from the predestimate layer all the way to the trephination mark before you start removing the posterior lamella. And finally, now that we recognize what a big bubble type 2 looks like, when you are removing the posterior lamella, you have to give a lot of attention to detail so that what you see here does not happen, where I broke into Descemet's layer. And some people will choose to stop, leave that posterior lamella behind, and simply graft the eye, although the visual acuity may not be as good. So try to be careful if you have a big bubble type 2 to protect Descemet's membrane. Maybe put a layer of viscoelastic before you place your scissors in that space. In conclusion, I like to consider deep anterior lamellar keratoplasty anytime I'm suspecting that the corneal endothelium is healthy, however extreme the case may appear. A successfully completed DALK has the advantage of a more secure wound, lower risk of allograft rejection, and the opportunity to decrease steroids in steroid responders. You can do that more quickly. Like in a game of chess, always be ready for the next move that the patient's eye may present you with. For those of you who are fans of chess, try to get your holiday sets soon because they're disappearing very quickly thanks to Netflix show The Queen's Gambit. Thank you very much for your attention.
Thank you very much indeed. That was terrific. I think we're a little bit behind, and I just wonder, Dr. Ammar, do you think that we can switch you and
I'm sure.
Dr. Would that be possible at all?
Pardon? You want me to talk now? No.
Can we switch between you and Dr. Daya?
Okay.
Would that be possible at all?
Yeah. Okay.
Perfect. Then we have more questions for Dr. Sadir and Nuj, but after you finish then. Well, thank you very much again. And I wonder if Shiraz is online.
Yep, I'm here. Can you hear me?
Hi, Shiraz. Great to see you. And thank you very much for joining us. We look forward to your talk, please.
All right, I'm going to try and share this right now. I'm not sure if I can follow well after Sadir's wonderful talk there.
We're a bit behind, but Dr. Agrawal was kind enough to give us his slide.
Yeah, thank you, Amar. I really appreciate it. I have a clinic teaming with patients downstairs. Well, thank you for inviting me to speak today on this topic of anterior lamellar techniques. I'm sorry we're going a little bit out of order because this is where these are techniques for the advanced surgeon. So basically, we've already heard about where lamellar techniques are indicated, so I'm not going to belabor that one. But there are times when, for instance, you see patients like this, where 10 years, 15 years after getting a graft for keratoconus, they get recurrent keratoconus, and they get ectasia in the host rim. And this is an OCT, an older OCT showing thinning at the graft-host interface and inferiorly, gross thinning and ectasia. So what do you do in these situations? Well, one of the options is to do a wedge resection. This was described by Troutman in the graft. But if they have normal tissues in the cornea, in the residual cornea, why not take that out instead? And that's a great technique for correcting huge amounts of astigmatism. And it's well worthwhile because you can preserve the graft in these patients. Traditionally, we were taught in fellowship to do a larger graft, take the whole graft out, put another one in. But those are endothelial cells that the host has tolerated. You should keep them. So this is the technique in a series of images. And we did this quite a long time ago and published on this. And we now have a very large series. You can see this is an example of an orb scan, 10 diopters of preoperative astigmatism, same patient you saw the OCT on. And now you can see that even though qualitatively there's much of a correction there, but actually there's 7.5 diopters of astigmatic correction in this patient. Now, what happens when the graft is really too small for that particular cornea? This is 25 years post-BK, and this patient actually had thinning 360 degrees. Well, the option again would be to do a large graft and replace this. Because the anterior chamber was quite deep, what we decided to do was a 360-degree wedge resection. And you can see that here, we tree-fined outside the area, removed that area of thinning up to the graft-host interface, and then sutured this down quite tight. And she went from about 60 diopters of astigmatism, which was unstable, it kept changing, to about 38. And over time, when the sutures came out, she did quite well. I don't think we have time for this video. I'll race through it in. So here you can see we're using the Metis dissector and a crescent blade at times where the graft, the corneal tissue is quite rigid, and using scissors where appropriate. So a variety of methods in your armamentarium to accomplish this, and just going very, very gingerly. And once the wedge has been removed, then we got to suture this thing up, and that's challenging because the graft is it needs to be flattened quite considerably. So what we do in these situations is do a paracentesis to release fluid in the anterior chamber, and that helps us get the graft closed. So it's just showing you the overall technique. And the other option is to do a deep anterior lamellar keratoplasty on the graft. And this is where if the endothelial cell count's not too bad, one can accomplish this. You're beefing up the cornea. And when I first did this in 1999, my intention was to beef up the cornea and then do a central smaller PK. The endothelial cell count was 600. I didn't think it was going to survive. And to my amazement, because it's a large graft, very little astigmatism, the patient had 20/25 vision afterwards, unaided. So I said, oh gosh, I did that as a proposed 2-stage procedure. Well, I should do this more often. And we published on that. And you can see this is the graft here. Now, can you tear the graft at the graft-host interface? Yes, of course you can. But we, as I say, we published this. This is a patient post-operatively, our very first patient. And you can see the graft-host interface and how big that corneal transplant is in this particular patient. We published this quite some time ago in Cornea, for those of you who want to look at it. Now, if we take these principles of lamellar transplantation further, well, what about pellucid marginal degeneration? That is a thinning in the peripheral rim of the cornea, or in the periphery of the cornea. Pellucid, meaning clear, marginal, meaning towards the edge, degeneration. Well, the central cornea, as you can see from the slit lamp image, is good. Why would we want to take out the whole cornea and do a full thickness graft or a large deep anterior lamellar keratoplasty? Why don't we just do a wedge resection instead? And we did this, and we had to use a variety of techniques. So what we do is we identify the area that needs to be removed, remove the stroma, and because we create a lot of striae centrally, we decided to dissect and remove separate Descemet's membrane from the patient's cornea. So it's easier to dissect the cornea from superiorly than it is inferiorly. So here I'm dissecting the whole cornea, and then I remove the stroma, which is like the wedge resection that I talked about earlier on. And there's air in the anterior chamber now to ensure that the dissection is fine. And this is what we're left with here, a diagram on my iPad that I drew to illustrate what we've actually accomplished. So the area blue is where I've separated Descemet's membrane from the cornea. And then once I've sutured up this wedge, then I inject air into the anterior chamber and oppose Descemet's membrane back onto the patient's own cornea again. This is an animation done by my nephew, hopefully illustrating this. So here we've removed the wedge, we've dissected off Descemet's membrane, and then we've sutured up the cornea, tightening it down, and then injecting air to push Descemet's membrane back up again. And this is the procedure in a patient, which I'm going to rush through now, just in rapid mode. This is a micrometer knife being used, making the incision here. An air in the anterior chamber, removing the wedge down below, or dissecting it. And here I started inferiorly, but this is a little easier going superiorly. Dissecting the whole cornea. And then suturing it up. And this is what the patient looked like afterwards. Preoperatively and postoperatively, you can see the marked amount of astigmatism, which is against the rule. And that's qualitatively a lot better. And this is a pellucid marginal, a personal wedge, a wedge resection for pellucid marginal degeneration with an inverted commas facelift, with sliding tissue across. This is some of our data, and you can see that the outcomes were very, very good. All patients were 20/40 or better at last follow-up. So the other question is, can newer technology help? Some of this requires a reasonable amount of skill, so it's not for the novice lamellar surgeon. Well, a femtosecond laser can be used, and we use a device from Bausch & Lomb that has got some good therapeutic features on it. And the advantage is that you can actually use OCT guidance to know exactly how deep you're going to cut. You can cut perfect circular cuts and even elliptical cuts, but it's limited by the software of the manufacturer of the laser. So this is a patient from Afghanistan who had an extreme pellucid of more than 6 clock hours in both eyes. And he was managing with scleral lenses, but in this particular eye, he had a problem. And the reason why he had a problem is because he got eye drops in the pellucid. You can see the area down below, which is opacified, and the OCT shows this heating up. So I took a note of that. He's got a hole there somewhere in his Descemet's membrane. I need to take that into consideration when doing your surgery. So this is his procedure. Is this running? With using a femtosecond laser. And what we did was we used 2 arcs for astigmatic keratotomies. This is the older version of the software. This was done quite a few years ago, probably about 8 years ago. And we did the central area first. That's the clear area. You can do the periphery. I had to do it in 2 stages. It means sort of double carding or using 2 interfaces or 2 licenses. But that's okay. It helps us to accomplish a better procedure on this particular patient. I wasn't sure I didn't have the courage to do 6 clock hours of a resection and in a patient who had eye drops. And because he was going to go back to Afghanistan, I was just worried about somebody following up if I had to wind up doing a corneal transplant on him. So here, this is the same principle again. I'm making a little incision with that diamond knife to do the dissection. And you can see he's really vascularized from a lot of contact lens use in the past, or abuse, as you might consider. And that's right, a bit of blood's a bit like glue. It helps seal the wound down. So here I am taking the wedge off. Now this is a speeded up video and not that rough a surgeon. And I know exactly where the hole is. So here I'm sort of splitting the cornea. It's quite interesting. Wherever you got a clear cornea, then very little stroma, it does separate from Descemet's membrane quite easily. But this area is also fibrous. So I'm going gingerly here with a pair of Vanna scissors, and just watch what happens here. It's a bit like one of Sadir Hanoush's videos now. So I'm grabbing this thing. I know I've got to dissect it all. Now you see the periphery did not dissect very well with the femtosecond laser. And there we go. I perforated at the site of the old eye drops. So yeah, no sweat. I anticipated that happening, and it's in the periphery. I'm going to be suturing that area up. It's going to close up nice and tight. I'm not really bothered about that hole in Descemet's membrane. All I'm trying to do now is accomplish closure. It's a huge red resection I've done there, and sure enough, it doesn't look very nice there. But once you've got all the sutures in, it actually doesn't look too bad. I didn't have to do a paracentesis. I sort of auto-paracenticized this patient, so his chin is quite flat. You can see there's a double bubble there. There's one bubble in the interface and another bubble inside the anterior chamber. And this actually patient did quite well, and is now in a pair of glasses. He did start slipping against the rule, so I cross-linked him, and then I'm waiting actually to do the other eye. So that's a potpourri of lamellar procedures. I hope you've been well entertained. As I say, this is not from the novice surgeon, but certainly well within your abilities once you get adept at doing lamellar surgery. And thank you for your attention, and thank you, Amar, for letting me squeeze in before you.
Great talk.
Right, thank you.
Yeah. Thank you very much indeed for being with us. I know that you're a heavy schedule.
Great, thank you.
That was wonderful, Shiraz. Thanks for sharing.
Happy Thanksgiving, Sudhir.
Thank you.
Other Americans watching.
Pleasure.
Dr. Amar, we're looking forward to your special talk on PDAC, please.
I'll just share the screen first. Okay. And let me know if my video is coming there. Is it there?
Coming beautifully, only.
Okay, lovely.
Yes, you're doing great now.
So first of all, I'd like to thank Anas and the whole Muscat Society for inviting me for this lovely conference of theirs. So what I'm talking is on PDAC, and I'm happy Sadi talked on the bubbles, big bubble techniques. So basically PDAC, which we had started in combination with Harminder Dua, we first did the first case in 2013. Let's look at this case. This patient was operated 6 times. The patient was flown down from Bombay to me and by a top surgeon there. The patient had just gone for a simple cataract surgery, and then, the complications happened. And by the time the patient reached me, you can see I'm doing the 7th surgery now. This patient wanted to commit suicide. Now, if you notice, I can't even see anything. So if you're not seeing anything, don't worry, even I'm not seeing anything. After taking out the epithelium, even then I'm not seeing anything. I made my flaps, and if you see, I fixed a trocar AC maintainer. What's the trocar AC maintainer? Is going from the sclera, but enters above the iris. Now I made my 2 sclerotomies under the flaps. I'm trying to do a little bit of vitrectomy. I'm trying to see if I can remove this scar tissue, so much which is present there, a little bit off. And you can see as I'm removing it off, it's firmly stuck so badly, even to the iris sometimes. So I'm holding it with one hand with a forceps, and with the other, I'm trying to cut and dissect it with a scissor. So you can see now slowly and steadily, I'm taking this all off. And while I'm doing this, notice my assistant is holding an endometer for me to see a little bit. So as I said, if you are not seeing, don't worry, even I'm not seeing much. Once I have removed this, things slightly improve. So now let's see what else am I seeing inside. And if you will see, I see something shining there. And once this is done, I'll do some more vitrectomy. And you can see the glistening structure there, which is a dislocated or a subluxated intraocular lens. Now, once I see this lens subluxated there, my first step is catch somewhere the haptic. I've caught the haptic anywhere. Now watch, I'm going to do a handshake technique. I'll transfer the haptic from one hand to the other till I can catch the tip of the haptic. Once I catch the tip, then I will externalize this haptic tip. So you can see my first haptic is out. Now that I'm out there, I'm much safer because now I know my IOL will not drop. So I complete my vitrectomy some more, as much as I can, to clear up the remaining mess which is inside the eye. But remember, my second haptic also has to come. So I can't see it again. See, I'm not able to see the haptic. So I'm trying to see where it is and catch it anywhere. Doesn't matter where you catch it. There, I've caught it somewhere. Once I catch it somewhere, I can always do my handshake technique. So remember, you need 2 forceps, 2 gluteal forceps to catch the tip of the haptic. Once the tip of the haptic is caught, I will externalize. Now, the point is, see how much of haptic is externalized in both sides. And you'll notice it's a lot. This is an important fact for us to know because you will need that much to tuck. So I take a 26 gauge needle, create my Gabor Chariot's pocket, and tuck the haptics inside. Now, so far, so good. Now I move to the second thing. I need to close this pupil. And this technique we started is the single pass 4-throw pupiloplasty. Remember, from one side, I'm just straight away going with the proline needle. You don't need a paracentesis. Remember, on that side, because I'm just going to go straight through the cornea, through the iris. In the other side, I have a paracentesis. Take a 30 gauge needle. It's such a simple procedure. Anyone can do this technique. Now, railroad the 2. Why am I doing this? Because when I'm going to do the PDEC next, remember one thing, my air will remain in the anterior chamber. 1. 2, any closed angle will become an open angle. 2. 3, I'm going to make my pupil a pinhole procedure so that any astigmatism will get neutralized. So now you see I pull this loop out. Now this is the single pass. I'm pulling out this suture out, this loop out, catching it and pulling it out. Once I have done this through the single pass, so remember you need paracentesis only on one side. You don't need on both sides because it's very tough to pass a needle through a paracentesis. Now remember the number 4. Just pass it 4 times and that's over. That's game, set and match. Pull on both ends and it seals it. See, normally you do 3, 2, 1. Here I've just done once 4 and now I've also made this many times till I've got a nice pinhole pupiloplasty also done. But look at my Purkinje image. It's bang centered on the pupil. Now, once I have done that, remember now I need to do my PDEC procedure. I'm just putting in air to see where the air is remaining. Now, my trocar AC maintainer will be connecting to my air pump so that I have continuous infusion of air. Any remaining desmaze, I'll just take it off right now. Now watch, coming back to the PDEC bubble, how do you create it? Sadiq showed it in the dark thing. The same procedure, is it? But here you're looking at the endothelium. Take a 30 gauge needle, go through the sclera. Now watch, I'm creating the bubble. The bubble does not go to the periphery. This is a type 1 bubble. So remember, where is the air? You have endothelium, you have desmaze, you have pre-desmaze layer or the Duas layer, then the air. Now what you do is, you can dissect this. So cut it inside, inject some trypan blue. Once you have injected trypan blue, now I have stained it, take a scissor, dissect, load it like you will do in a DMA graft, any way which you want, and inject it inside. Now remember, the big advantage in the PDEC here is, one more advantage I get is, 1, I'm able to use only young donors. I don't go above 35 or 40 years. Second, I can manipulate the tissue, unlike a DMEC which will tear. So once I have unrolled the graft, my air is inside, I apply the fibrin glue. And once my fibrin glue is applied, this is the way the case looks when it's complete. So now let's see the patient. This was the patient pre-operative. Now let's see the patient, same case, post-operatively, 15 days post-op. And once you see that, look at the same case, pre-op, 45 days post-op. What have we done? We did the gluteal, we did the single pass 4-throw pupiloplasty, and we also did the PDEC. Saying that, I'll now move on to the second and the final presentation, which I wanted to show you is about another case. And in this case, what we are going to show you here is, look at this patient. This was a one-eyed patient, okay? And he had come from long distance, flown down. He has silicone oil in the eye, but he has obviously got this pseudophakic bullous keratopathy. This is the fellow eye. There is no perception of light in that eye at all. So now what I'm going to do is trying to take off that epithelium. Now, once I've done that, I still see silicone oil obviously is in the eye. So I'm fixing my trocar AC in the eye. I also this silicone oil. Very simple procedure is just make your flaps, side port incisions, and you can take off that silicone oil. But there is in the back also. So you notice some of it is coming through some break there in the capsule also. So what in such cases we have to do is, I need to close this pupil down. So again, simple, we are doing a single pass, 4-throw pupiloplasty. In this case, I am not doing a glued IOL because I thought my lens is quite stable. If it was not stable, I would have done a glued IOL also. But in this case, I think just the pupiloplasty will suffice. So you can remember it, single pass, once done, 4 throws, remember that number 4 times, and that's done. You don't need to do it 3-1-1 or 3-2-2 or whatever technique you want, just once and it's completed. Now, once you have done this, I still see, I want to make the pupil some more smaller. So in this case, I might do some more pupiloplasty. Now I've injected air inside through the trocar AC maintainer, and I'm going to take off my bad endothelium desmase complex. So once I have removed that, you can see the whole desmase complex removed there finally. And you can see there the whole structure coming out just like you do your normal procedures. Now you see I still found some oil present there posteriorly. So I'm just trying to remove some silicone oil from the vitreous cavity. Now I prepared my PDEC graft again, like I showed you before. The point I want to mention is many people discuss with me about DMEC and DSEC. We do about 100 keratoplasties a month in the Agarwal hospitals, and we do 0 DSECs and 0 DMECs. Simple answer is this. Remember, when I do DSEC, obviously you're taking 80 micron or whatever it is. So I'm taking extra thickness. So obviously it doesn't make sense to me. Why do we not do DMEC? Let's understand, in DMEC, the endothelium and desmase is stuck till the donor is 40 or 50. That means my DMEC donors are much older, which I don't think makes sense compared to PDEC. Whereas I play with PDEC, I can play with the youngest I've done is a 9-month-old donor. Also, the manipulation of the graft makes it a big advantage. So looking at this, we always feel the PDEC gives you the advantages of both DSEC and DMEC, and without the disadvantages of either of the procedures. Here you can see the graft unrolled there. Once I have unrolled, my air pump comes on there, and I can then manipulate the graft whichever way I want. Now the question comes finally, how did this patient behave? Remember, this was a one-eyed patient. So this is the only eye of this patient, and he's able to at least walk around a little bit, going to the washroom. So I had to be very careful. Even that is not lost. So this is the pre-op. 1 month post-op, you can see how the patient's vision has improved. And look at the fellow eye of the same patient. And you can see now the patient 3 months post-op, how the cornea has cleared. And once again, as you can see, the fellow eye of the patient. Saying that, the last picture, which I thought I'll just show you in a second, is to explain this better, we thought we'll bring out a book. And so we published this book on PDEC alone, which is published by the JP people. So those who would like to read and understand this procedure more can always get it from these publishing houses. I'd like to thank Anas and also the entire Muscat Oman Society for inviting me for this lovely conference. Thank you very much, Anas, Rashid, everybody.
Thank you very much.
Yeah, thank you enough for being with us and for being generous and flexible as well.
Thank you, Dr.
That was wonderful, Amar.
Thank you, Sadir.
Great talks. Yes, thank you very much.
We have barely 15 minutes with some extra time for Professor Alio. So without further ado, please.
Welcome, Dr. Alio.
Thank you very much, and happy to be here, Rashid and Anas. Thank you for this invitation. I'm enjoying very much this session with such a nice group of friends. So let me share with you this presentation, which is now devoted to the use of endosecond laser for corneal graft surgery. So the point with this presentation is to show to you our experience and what is the use and the expertise that we have gained with this procedure. So we have obviously problems and pitfalls with the conventional surgical graft techniques. First, that we have an unprecise sizing of the shape and donor and the recipient, because manual trephines have a pressure in the eye that is uncontrolled and is variable. The wound configuration as a consequence is variable. The donor-host interface is unpredictable, and the wound healing consistency is so far unpredictable as well. And based on this, part of the problems that we have with refractive outcome, which is by definition unpredictable as well, are very affected by these variables, and if they could be controlled, probably we could have a better outcome as well. And the trauma to donor tissue in this type of eyes in which we have very low pressure or we have an uncontrolled action of the cutting elements is also uncontrolled. This is why femtosecond laser should allow better control of decision, design, and profile. As far as we are allowed to make new creative designs to optimize the donor host, a position, the graph stability, and the placement of sutures should be in favor of better outcome, is particularly in the outcome of astigmatism, and it should be an interesting tool to explore and to use in corneal graft surgery. So we have as a definite advantage that we have a more accurate tool, and this leads us to accuracy in size and shape of the donor and host incision. We can customize the wound configuration to promote a better healing. We can also improve probably suturing technique, and the control of wound healing could be even influenced because of the large amount of tissue that we can make in interaction with the creative designs that we have in the profiles. So the wound healing and stability are the most outstanding issues that should be accomplished with femtosecond laser. We use femtosecond laser in penetrating keratoplasty. Have to tell you that most of our cases, also in femtosecond DALK, most of our cases, but we don't use it so far in the SEC because our preliminary results were not good, and I'm sure that the MEC will be one of the next steps in which we start using it once that the less energetic lasers are introduced into the practice, because with some of the models that we have now, we cannot do this SEC, and indeed the closer we go to the endothelium, the more the problems we have in the endothelium as well. So what customized cut patterns you can do? And I'm going to refer basically to the intralis technology, even that we use several techniques. With a customized, which is the more versatile of all, we can make these profiles as the more frequent, but you can really design whatever you want. The issues that we can decide in top hat to remove a lot of endothelium and decimate in favor of getting a larger substitution of the deep tissue.
I'm sorry.
Yeah.
Have you shared the screen, Professor Alio?
I did. So you have not been able to share with me?
No.
Oh, I think that was my mistake. I didn't care of that.
It's okay. At the bottom, there's a green line.
No, I know. Do you see it now?
No.
Okay.
You have to give a click on that share screen button, green one at the bottom middle.
Yeah, I know.
Yeah, so after that, you'll be able to see that screen option in there. So just give a...
I pressed it already, my friend.
Perfect. Your screen is shared now. Now open the presentation, doctor.
Yeah. Probably it was on now?
Yeah.
Yes.
Okay, so sorry because I will not go through the previous slides. I apologize for this, but I thought I did it properly. Probably didn't click it out to the end. Okay, so we were talking about these patterns, and the patterns are important because the more tissue to put in interaction, the more healing you are promoting, because you have a more consistent and large healing surface. But troncoconic patterns are the ones that we use after going through all these patterns, and these are the ones that we prefer. In PKP, we use the troncoconic pattern. We found that is the one that fits better because reasons that we shall talk about later. While in DALK, we use the inverse troncoconic. And the reason is that we tried not to reach to the peripheral part of the decimate membrane, which is where we have most of our perforations when we are doing DALK. So we prefer to limit it to this initial 7.5 to 7.7 millimeters. And we have reduced, in doing this type of inverse troncoconic, the perforations that happen to be in DALK when performing the big bob. We can have all these patterns that obviously can be done in the donor and the recipient in a way that it's like putting a cork in a bottle. The need of sutures is indeed less, and you fit the tissue in a much better way. This is one of the profiles. These are the parameters that we use for the troncoconic. That is troncoconic profile in PKP. The reason to use this is because once that you put the donor into recipient, the pressure of the eye is pressuring the donor against the host, and then you close the wound, and the implantation of the sutures is much more facilitated, and you have this as an advantage in the surgery. This is the way in which we perform the laminar graft. These laminar grafts, with or without the both big bubbles, sometimes we do, like in this case, superficial laminar grafts. Then we do the troncoconic invert, because it's just the contrary. We try to be more in the external part in diameter, because it's the one that has the problem, unless in depth, in order to prevent, not in this case, when we go to the big bubble, the perforation. This is one in which we're going as deep as 80% of the total thickness in order to go closer to the internal and deep tissue, and then we proceed with a big bubble in the remaining stroma, something that we have found in our hands to be much more suitable and faster surgeries performed in this way. So what we should expect, and we see now what we have gained and what we have not with our experience, an improved wound healing, stability, with faster recovery, less potential trauma to donor tissue, better asthmatic outcome in cylinder, cynical power regularity, and probably we can get earlier suture removal and reduce need of stitches, because we are putting more tissue in contact because of this type of patterns. So other advantages are the capability to perform special cases. For instance, to perform in special cases like in perforated eyes, this type of surgery. This is a case in which we performed in a case of acanthamoeba keratitis that was not performing well with the treatment. We were referred after 1 month this case and had a central microperforation, and microperforation is considered as a contraindication for PKP. Because we increase the pressure and the suction should increase the filtration from the anterior chamber. You will see now that this is not the case. This is the Seidel phenomena that we had in this case. Look at the filtration with fluorescence of this case. So this was a perforated eye. Even there was a little bit hypothalamic. The issue is how to handle this case. You know that manual trephination in these soft eyes is very problematic. Even that you use viscoelastic in the anterior chamber is not easy to do. And what we did, and you can see here, is we performed the topical anesthesia. A paracentesis, the patient was cooperative enough to do that. And then we put the femtosecond, we first filled with helium-5 the anterior chamber. We don't use in phakic eyes other than helium-5 because the others, especially visco, as you know, can induce toxicity in the crystalline lens. And once that the patient had an anterior chamber that was reconstructed because it was hypothalamic, then we went with a suture, with a suction ring in order to block the eye. As you see, we are getting some visco, but remember it's helium-5 through the microperforation. But immediately after, and look how we are getting the helium-5, we are just pressing, and then with the pressure of the cone, we block the exit of the viscoelastic. So with this in mind, we could do the pattern that we selected. That was a zigzag pattern, and we could do a very nice zigzag pattern. Following this, we perform local anesthesia and we proceed with all the surgery as normal. You know, this case demonstrates that in perforated eyes, you can have this chance of using the intralace and any other of the femtosecond lasers, blocking the perforation in order to get the adequate profile. In this way, we create a much more perfect profile. Here is like we're removing the full graft because we don't laminar grafts in these cases with infection. We did an 8mm graft, and finally the surgery was performed with the adequate stitch technique. This is the way in which we are doing the donor, and we're not going to lose more time with this. This is the way in which the case was finished. You see that we had a beautiful outcome after 1 week, and the case finally had this appearance. The healing was very good. As you see, we had a very fast healing. Look at this white scar that actually is a scar coming from a lot of tissue that is interacting, and this scar was happening at 6 months. So we got a very nice outcome with -2.5 of astigmatism, with very good vision, with very adequate irregularity, and the zigzag pattern proved to be quite stable and very nice in this case, in which we have been following for 5 years with no relapse of acanthamoeba. We have in keratoconus most of our cases with deep anterior laminar graft. This is our standard technique. We don't do penetrating keratoplasty unless we have a hydrops with a posterior perforation, because in these cases, in our hands at least, that has not made any benefit because the central scar is always limited the vision, and we do in all these cases femtosecond assisted tap. We don't use it for the deep incision. We do only for the side cut, and the side cut is performed down to 80% of the local thickness calculated by OCT. This is how we do the tomography. We use OCT for the tomography. With the tomography, we calculate where we are going to make the graph, and based on that, we calculate 80% of the tissue that is going to be cut by the femtosecond. So as far as we cut this type of technique, we were initially using this technique, which is the mushroom. The mushroom was very attractive for us because we are removing most of the anterior part of the cornea, which is where the abnormal keratocytes are being housed, while we limit the posterior size to the diameter of 7.7 in order to avoid the peripheral perforations, which is where we've got most of the micro perforations in our technique when we're dissecting the peripheral retina. So this is how we are doing this, and this is how we calculate. We make a disparity of 0.5 to 1 millimeter in the cases that we use this technique. The real thing is that we use the donor preparation, the Moria 1. The Moria 1 is a stainless steel. It's very solid. It's the one that we prefer. We have this unit for many, many years, and it's cost effective. It's doing very well. And we have this femtosecond assisted ALK in quite a number of cases. What I'm going to show to you is now the study that we performed with 10 years experience using deep anterior laminar keratoplasty in keratoconus. The results that I'm going to show to you have been published already, and you can read these papers in which all our experience is reported and analyzed with many important information that you can get for the practical use in your practice available. What we found after 1 year, comparing a randomized series of cases of femto versus manual deep anterior laminar graft, is that we got not significant differences in the uncorrected visual acuity at 1 year. So we got no difference in uncorrected, and this is the way in which we were analyzing. We have in the manual about the same results with you take into consideration this standard deviation that in the femtosecond assisted, and in best corrected visual acuity was not at 1 year having any benefits. So we were quite disappointed that we didn't have any difference in the refraction, the refractive outcome between the manual and the femtosecond, considering the refraction. This is how we got. There was a trend initially to have better best corrected vision in the femtosecond group, but once that the sutures were removed, both did the same. About the analyzing just the ceiling and not the refractive outcome in terms of spherical equivalent, we didn't get at 1 year any significant difference either. So we were quite disappointed as well, as far as we didn't got any best corrected visual acuity difference, and neither any difference in the cylinder, what means that we were inducing about the same level of irregular astigmatism and definitely the same level of regular astigmatism. Look here that there was a slight trend, but very, very slight, with less dispersion in the femtosecond laser group. Indeed, they did initially at the beginning better, but later on, especially when we removed the stitches, they did the same with no difference at all between the two groups. What we got, and this was evident along the study that we performed, is that we get a different type of healing pattern in the manual and in the femtosecond. It was clear, you know, we published in cornea this grading of the corneal healing that happened in femtosecond laser, and was totally different than the one in manual. We call grade 0 when we had transparent scar with minimal healing opacity, grade 1 when we had faint healing opacity, as you can see here in this sample, grade 2 when we had evident healing opacity, grade 3 with this healing opacity had a circular scar or was present in 2 quarters and created a cosmetic imbalance that was indeed much more important in pigmented eyes, while in grade 4 we had a healing opacity with a very important cosmetic imbalance like as the scar was visible, and not only that, the scarring was visible through the channels of the sutures. That means that we had along the suture a scarring process that was the healing pattern was significantly different in femtosecond and manual. So in other words, we were creating larger scars. That means more important healing pattern in the femtosecond, probably because we are activating the keratocytes with a femtosecond that creates a faster healing. These are the severe healing patterns. You can see that in manual laminar grafts, you seldomly see this type of patterns with the type of healing stars, with the channels of the stitches occupied by scars, or with this cosmetic imbalance that happens in some cases. And this was subepithelial scarring that was present, could be removed by hand if you remove the epithelium, and then with aggression knife you remove the scar, but it was a scar that was visible and was permanent in these cases. So this was the case. We discovered and we described that the healing pattern is different in femtosecond DALC and in manual, but probably is the only one advantage, and indeed it's an advantage that we like a lot. Let me show to you some healing patterns. You look that in this case that you have a healing pattern grade 2. You can see in the OCT scan, this healing pattern affects the superficial layers of the cornea and is mostly subepithelial. This other one that you see that in this temporal inferior area, you have this abnormal healing, which is an overhealing in a case of super Mosrom case. This was particularly visible in those cases in which we left a large part of tissue in the Mosrom, in the superficial, probably because the superficial part of the cornea harbors most of the keratocytes, and the healing pattern, as far as it's stimulated, is more and more violent and important in these cases as well. Look here in this other healing pattern, how we have superepithelial scarring, and scarring that is going through the channels of the stitches as well. This is one of the most advanced, is a grade 4, in which you have a cosmetic imbalance, and indeed this is not adequate.
I'm a little bit involved in another.
Yeah. Okay. Okay. So as a summary, and I'm finishing, there's we get definitely an increase in the precision donor host sizing. We have better side cord profiles, very innovative, but we have increased wound healing. We have all the advantages of a femtosecond surgery, but we have not the better results, probably because we need to know how to handle this over healing, which is in favor of removing the stitches earlier. So probably early suture removal was expected to give better results. This is exactly what we are doing. We published these results in this book, in which all of our experience about femtosecond laser assisted keratoplasty was published. And then we have more information in this online course that we do in our university on refractive cornea cataract surgery, that we have 250 to 270 multimedia hours of teaching activities in English, and you can get through this webpage information about this course, in which most of this information is released as well. So thank you very much. As a conclusion, we perform today all our graphs PKP and even the Larmor graphs in most of the cases as well. With femtosecond, we find the advantage of a better surgery. We don't find an advantage of better refractive outcome, but we are removing the stitches earlier, and probably we are going to create a different protocol for future removal according to healing, that will guide our process of stitch removal in a much more precise and much more scientific way. I thank you very much for your very kind attention.
Thank you very much.
Thank you very much for the great talk, and for being with us despite your very busy schedule. We barely have 5 minutes. We have questions for Professor Hanoush as well. So do you want to start, Professor Hanoush, or?
Do you have a question for me?
Yeah, it's about when to remove sutures and how does that affect the refraction outcomes.
So in the early days of DALK, we thought one of the advantages of DALK is early suture removal. We were wrong. We discovered that because the posterior lamella close to the trephination area was not completely being removed, there was anterior displacement of the DALK graft, and therefore early suture removal led to flattening in that meridian and significant astigmatism. So I'd say in around 2013, 2014, as we got better at DALK, we started delaying suture removal. So for someone who uses a 16 interrupted technique, you may want to wait at least 3 months before starting any suture removal. And even then, no more than 2 sutures at a time.
All right, and some people suggest not to have 2 sutures next to each other at a time.
That's absolutely true. That's absolutely true. I never remove adjacent sutures at the same time. There's no reason for that because you cannot predict the response of the cornea to suture removal. So it would not make sense to sacrifice a whole eighth of, like 1, 2, 3 clock hours if you do that. Not a good idea.
Thank you very much. Professor Adia, any preference with sutures removal with the FLAC surgeries?
Well, and as we use always a double torque anti-torque suture, which we have found in our hands to be the less astigmatogenic. Having this in mind, we have astigmatism. It's the main problem in the outcome of corneal graft of all types, including the anterior laminar graft. So we are, at this moment, in my opinion, getting better outcomes by guiding our suture removal by the OCT analysis of the wound. So what we do now is with a high resolution OCT, we study the cornea and we have patterns of wound healing depending on the density of the opacity that we see and the depth of the opacity. We infer from this how is the level of healing, and based on that is when we remove the stitches. Doing that, we have a lot of fun, but let me tell you that I don't have the evidence to have better refractive outcomes so far. So suture removal is part of the business, but it's not the only one business. We have a donor tissue being housed in a host cornea, which is abnormal, with biomechanical problems, with elasticity, which is different. So I think that we are far from today to solve the problem of the astigmatism that is left in corneal graft, either dark or penetrating, because it's not about the incision and it's not about the suture only. It's part of that, but it's about how we are putting one tissue normal into another that is abnormal from the biomechanical standpoint. So even with this sophistication that we do now, which is a lot of fun, and I think that we are learning a lot about the corneal behavior in terms of healing after corneal graft, we are unable to find a better refractive outcome by the policy or suture removal guided by the healing pattern by OCT. But it's a lot of fun, and definitely we have, in my opinion, the better knowledge about what we're doing in the cornea. What the mean astigmatism that we get is about 4 diopters. That means that sometimes we get 2, but many others we have 6. Certainly we have more than 6, and then we finish these cases with a toric lens in a third chamber. That is not the topic of this round table, but definitely is the way in which we finish this surgery. We always want to have the toricity of the patients corrected by an intraocular phakic lens, which is feasible in these cases. Thank you.
Can I ask Professor Aliou a question?
Please.
Or Jorge, the question to you is: you had this very elegant comparison between manual dissection and femto dissection for DELC. For the manual dissection, was that with the employment of a big bubble technique, or was it a layer by layer dissection? That's my first question. And then the second question is, did you ever look at your conversion rate to full thickness transplants between manual dissection and femto? Because I assume with femto, you had no reason to convert any time, but with manual dissection, especially employing the big bubble technique, there may be an incidence of conversion to full thickness.
Yeah, thank you for the question. About the conversion rate is 13%. 13 is what we get at this moment, and I'm talking about the last 100 cases. About the first question is interesting, and most of the cases are big bubble. Most of the cases. When we have cases with no big bubble, and you know that you get this type of cases, no big bubble happens in about 15 to 20% of our cases. Then we do this layer by layer, and then is in these cases where we get most of our 13% conversion. So we have the big bubble as our preferred technique. As with you, we didn't recognize initially between the type 1 and type 2. We got about 20% of conversion, and since we are using the femtosecond, it's about 13% precisely. And we have indeed only perforations in these cases, most of the cases, in which we need to go layer by layer because we don't have any bubble. Something that happens, as I told you, in about 20% of our cases.
Thank you very much.
Thank you.
Thank you.
All right. Just one quick question. Anything special if we encountered a rejection post DLK and opacity? Anything special on how we change the cornea in this instance? It's for both, for Professor Hanoush and Professor Aliou.
All right. So the most important thing about rejection with DELC is that by definition you do not have endothelial rejection, but that does not mean you cannot have stromal rejection. So all of us who do DELC have witnessed stromal rejection. It's a real problem. And sometimes it can be very aggressive with vascularization of either the stroma itself of the donor or the interface. And the only way I know how to handle it is by increasing steroids and frequently placing peribulbar steroids. Now, some of us are trying to work with Avastin, an anti-VEGF agent, to try to limit vascularization. But frankly, that's a rare phenomenon. If it's recognized early, it can be reversed with steroids.
Same with us. You know, we have about a 5% rate of stromal reaction. I'm talking about numbers. You know, I haven't seen an stromal reaction in the last 2 years. But if we analyze, we have about 2 to 5%. These cases, all of them have been controlled by topical steroids only, you know. And I agree with you, Handos, if we have, by any reason are stitches or the chronic epithelial defect that happen at a given time of the patient in the neovascular growth, then we treat it with Cautery and Avastin, and very successful. Reaction is not happening, obviously, in the endothelium. And epithelial reaction happens in about all the 5%. So we have about 5% of epithelial reaction. About the number I told you about stromal, all of them have been always treated properly with the adequate use of steroids. So it's not a problem, you know. The problem with the graft is when you have a conversion. And then when you have a conversion, you have a big disappointment because you are not expected to have a PKP. And then you have a large graft because we use 8 or 8.2 millimeter diameter DALC. If you have a 8 or 8.2 PKP, the risk of reaction increases. So my question to you, Hanus, now is which is the size of your DALC on regular basis? Because we know that the larger the graft, and if you end in a penetrating graft, you have a larger risk of reaction. What do you do? Well, what is your preferred and favorite diameter for DALC?
Right, so we use an 8 millimeter.
Go ahead, please.
We use an 8 millimeter graft most frequently, sometimes 8 1/4 and rarely 8 1/2. Now, mind you, with the Hana Trefine, because we have an obturator, the cut is very vertical. This is the Hana Trefine from Moria. The cut is vertical, so we do not feel we need to oversize the graft, except in certain instances where there's a very advanced cone and we need to make sure that we don't end up with a loose decimi layer complex. But my standard graft is 8 millimeters, and that seems to work well. And I use the same size donor and recipient. Obviously, I'm punching on the recipient side, on the endothelial side of the donor, and I'm trefining on the epithelial side of the recipient. We use the same size graft.
I have one question, please, or maybe for Dr. Hanos, Professor Hanos. How we can read DALC post-rejection, and if there's opacity also? If we want
Dr. Saidi, would you kindly repeat the question?
How can we repeat DALCs for those having rejections? Any special precaution, or those patients develop opacity? We can do DALC again, but how? Could you explain this?
Well, as you know, the best way to manage a complication is not to get it in the first place. And I'm not trying to be funny about that. All surgeons know that, right? So basically, even though arguably the advantage of DALC is to be able to wean the patient off steroids, I do not wean the patients off steroids early. So I have the patients on at least 4 times daily steroids for the first 3 months. And I rarely drop below twice daily, unless there's a steroid-induced pressure elevation or a complication. Now, if you do have rejection, then we increase the steroids, as Professor Aliou mentioned. And then when we cut back, we always cut back to a level at least 1 drop a day more than when the rejection took place. If you have an opacity that's visually significant and cannot be corrected with a rigid gas permeable material, then the nice thing about DALC, as you all know, is to simply remove the graft and repeat it. If you had a successful big bubble type 1 graft, you can very easily do that when that happens, even though it's a rare phenomenon.
Thanks.
Again, yeah, you know, one of the nasty problems is to have double anterior chamber. You know, double anterior chamber happens sometimes when you have a microperforation, but sometimes you have them spontaneously. You know, and this is one problem that you have to handle. So my point is now for all of you, how do you handle double anterior chamber? How do you make any preventive measure, and which is the frequency you find the stressful condition?
I have a lot to say about.
I would like to listen to Professor Hanoush.
Yeah, I mean, I have a lot to say about that because and I discovered this the hard way, of course. So here are my only trick about avoiding a double anterior chamber, especially, Jorge, since you mentioned it can happen without perforation, is very careful suturing, right? So when we first started doing DELC, we inserted our needle in the interface. And because we wanted to push the donor as far posteriorly as possible. But with passing the needle through the interface, there could be micro perforations in the pre-decimi layer that you may not notice until the next morning. So now we go very deep in the host, but not into the interface between the pre-decimi layer and the host. So we stay a little bit more anteriorly. With a full thickness graft, we teach our trainees, go as deep as you want, but don't go full thickness. Here, I'm going a little bit shallower. As far as management of the double anterior chamber, two things. One is the common thing that all of us do, and that is to put a bubble in the anterior chamber and position the head in a way to seal the defect where you think it happened. But one message I've been trying to spread over the past few years, which people don't do, in the office on the first postoperative day, which is when you notice the double anterior chamber most commonly, I don't just put a bubble in the anterior chamber, I also burp, B-U-R-P, I burp the interface. That means I insert a blunt spatula at the graft host junction, just enough into the interface to burp that aqueous pocket from the interface. Now, it's not always an aqueous pocket. Occasionally, as you know, it's retained viscoelastic material. But what I do always, bubble in the anterior chamber and a small parting of the graft host junction where I think the perforation took place to allow that aqueous or viscoelastic that's in the interface to come out. And if you do that, because the endothelial pump is working beautifully in these patients, before the patient goes home on postoperative day number 1, you can defervesce the donor cornea once there is full apposition of the host decimi membrane Duas layer complex to the donor.
That's excellent, really. Great time, and we're both pleasure and honor to have you. I can't thank you enough. Dr. Rashid, anything to add?
Thank you. I got all of the feedback that they said very great sessions. Everybody sending to me message in my phone. It's very great, well organized, the best speakers we got, and we thank them. Without them, this won't be so. Thanks, Dr. Sadir Hanoush and Dr. Alilio and other Dr. Agarwal and those they left. Really, thank you for your valuable time you gave us, because now we're working time with you. Thank you very much.
It's an honor to be with you.
Okay. Thank you very much. A pleasure.
I highly appreciate it. We'll see you soon.
Thank you.
Bye now.